Hi everyone. My name is Husna and I'm one of the hematology registrars currently working in the UK. In my last few months of training, I've just thought of creating this YouTube channel called ClinHaem. Uh, because clinical hematology is generally perceived as quite a complicated specialty, which it really isn't. But I hope with this channel to make things easy for people who are interested in clinical hematology, but also preparing for FRC path exam or other hematology exams. In the first video here, we will try to go through the specialty and I will present a brief review of the specialty itself. And this will be the layout of what we are going to discuss today. I'll start with what clinical hematology exactly is, then how the specialty is in overview, what are the pros and cons, and why I chose clinical heme, and if this is right for you as well. And finally, I will discuss some future plans for the channel. So, I'm sure you guys already know, but clinical hematology, as the name suggests, is a specialty that deals with management of blood disorders. It's a clinical specialty, but actually includes lab aspects as well. Historically, this hematology only used to be lab-based, but throughout the world, there is now a push towards clinical hematology. So the lab aspects include, but they're not limited to, understanding and blood's film and other morphology like bone marrow morphology and lymph node morphology. Um, Overseeing lab functioning is also one of the roles for some hematologists, especially related to the blood tests that we do in hematology, like the usual full blood count, coagulation screen, etc. And a hematology consultant with interest in transfusion would usually be responsible for running a transfusion lab in which basically they will be working in conjunction with lots of very experienced BMSs, which is biomedical scientists, and any complicated questions or scenarios would be coming to the transfusion medicine specialist. That complicated as in what are perceived complicated, but they are actually not, hopefully, as we will discuss in future series. So it's divided into four main subspecialties at the moment. The first one is a journal slash medical hematology. It's also called classical hematology. And this involves the most common problems such as anemias, thrombocytopenias, red cell hematology, such as thalassemias, etc. Malignant hematology, of course, deals with the blood cancers like leukemias and lymphomas. Hemostasis and thrombosis is the one of the most tricky ones here, where this deals with not only disorders that put you at increased risk for bleeding, like hemophilias, but also deal with complicated, again, for those who don't know it, complicated uh, scenarios of day-to-day anticoagulation. And those expert in hemostasis and thrombosis are really good at balancing the bleeding and thrombosis risk. They're quite sharp clinicians. And lastly, of course, transfusion medicine, which deals with a lot of lab-related transfusion steps primarily, but they have got clinical roles as well, as we will discuss. Okay, so the big picture. So what do we actually do? As clinical hematologists, we do everything that a clinician does. So seeing patients, treating patients, speaking to patients, giving them good news or breaking bad news sometimes, unfortunately. But in addition, we also do liaison hematology. So we, of course, as with other specialties, we will provide help with hematology related queries that are coming from in the hospital, from different specialties, or even outside the hospital, like from the GPs. And this is for me the most satisfying aspect of the job sometimes, because it is quite rewarding to help somebody with their question and ultimately help with the patient care. Morphology and hematopathology is a really interesting field as well, and this is where you get to taste a bit of detective work, looking at a blood film and then diagnosing a disorder from the blood film picture is really rewarding. It's really satisfying. And we also do some procedures as any clinician does, but in specific to our specialty, we do some bone marrow biopsies and intrathecal chemotherapies, which means giving chemotherapies directly in the intrathecal space. And this is probably my least favorite part of the specialty, but you have to do that as part of the job. A typical day would look like this. So a person would do a ward round or clinic, and then they would see blood films in the lab, either for their own patients or the ones that have been referred. And mostly the inpatients in hematology are those who are um, having some problems that cannot be managed outside. So people who might have had some side effects from chemotherapy, for example, or sometimes some elective chemotherapies might need to be given as an inpatient because they're just too much to be done as an outpatient. But our chemotherapies are actually predominantly moving towards outpatient to be given in the outpatient setting, which is actually very good for patients' quality of life because it's not nice to be stuck in a hospital just for chemotherapy. Um, and it's yeah, MDT, so once a week or twice a week. We would do an MDT. So one MDT would be intra-specialty, so that's called the grand round, just to go through patients who are inpatient. So that's very useful because you can get to hear other people's ideas even if you are attending, but you can get an input from all the other members of the team. But also, of course, because this is a specialty that deals with cancer care, so we do MDTs outside the specialties with clinical oncologists, radiologists being present, etc. And of course, if you're on call, you will deal with the on-call queries as well. Some of these are routine and some would be urgent. And some hospitals, you are the first point of contact for the day unit as well, where people would be having blood transfusions or chemotherapies, etc. And any problems, they will give you a ring. However, in most hospitals, actually, there is a resident doctor who's the first point of contact, and they would be able to deal with 90% of the problems themselves. So moving on to the pros and cons. So as I said, it's quite an intellectually stimulating specialty. You have to have a good background of the physiology and pathology. Again, seen this is probably seen as the most complicated part, but actually it's quite nice to know how things work. It provides a unique combination of clinical and lab work. It's very rewarding because, especially these days, because there are lots of treatments for lots of hematological conditions that we didn't have previously, and we've seen excellent results, and there are many cancers that we can cure actually. So that's really good. Um, it's quite a niche specialty, and many a times you will probably be the person who people would refer to because they will see aspects of hematology too complicated for them from people from medicine, cardiology, any other specialty, even though they might seem simple to you after working a year or so in hematology, but just because there's very limited exposure outside of the specialty itself to hematology, people are not very familiar, so that feels quite you feel accomplished, so to say, as well, which is good. And there are lots of rapid advancements happening quite rapidly in the specialty. So I was away in a peds hematology rotation, for example, and by the time I came back in 4 months, they had two or three new myeloma drugs that they were using. And for me, the most important point that I probably joined hematology was that there are no 2 days are the same. And that's really true because even though the illnesses and the diagnoses are similar, but no 2 days are the same because you get new challenges and new problems to solve, which is good. Of course, coming to the cons, I mean, there are exams, as with many other specialties, but some people see them as a downside. But I actually think because of the exams, you are actually forced to take time out to do some reading and actually become better doctors. So I don't see that as a con, but people do. And the exams are difficult, or considered to be difficult. Any exam is difficult until you have done it. So now that I've done them, retrospectively they feel, oh, that was a okay exam. But now, if I had to do an exam, then I would of course feel the pressure and things. So the stress that comes with the exam is there. There's a steep learning curve in morphology because, of course, we have very limited exposure. But as you pick things up in a year or so, and there are lots of resources now to get your morphology sorted. And I'll make a separate video about that if you guys are interested. Um, yeah, this the only con that I think is that we get minimal exposure during medical school and during the medicine training to hematology because all the quote unquote hematology problems are, designated as complex issues and to discuss with hematology and people who are otherwise very clever and smart actually do not do any brainstorming towards minor blood count abnormalities, etc. And that's not their fault. That's just, we're just not exposed to this at all, even though full blood count is the most common test, for example, that's done in medicine. And any minor abnormalities people get a bit anxious about, which is understandable because of their limited exposure. Now, some pros and cons, specifically in context of UK training. So one of the very good plus points that attracts people here, apart from being clinical, lab work, intellectually stimulating specialties, that on calls are non-resident. So after your medicine training for your IMT training, you practically are on call after in out of hours. If you're on call, you will be at home. Most 99% of the hospitals do not have resident on call. So that's really good because you can get some sleep in most of your on calls, which you cannot, of course, if you are a resident, on call. So that was really important for me because I really like my sleep. And I was actually not, it was during my medicine years, for example, the sleep was affecting me quite a bit. So that's really helped. Of course, there would be nights where you wouldn't be sleeping, but then you won't be going in the next day to work. There would be arrangements locally for that. And the other very good positive thing is that you only cover hematology issues because you're not on medical on-call rotas. And I've done some some medical registrar work here very briefly. And the thing is that it's very difficult. I mean, some people actually enjoy it, but for me, it's difficult to manage all sorts of random stuff that you are hardly ever exposed to. So, say if you haven't done a respiratory medicine job or you are not training respiratory medicine, then you'll be a med reg, and overnight, if they have chest drain problems, you will be called for. So, imagine a pneumothorax patient having chest drain problems. So, things like that. So the cons are, yeah, the on calls are non-resident, so you're basically relying on someone else's view, which can sometimes be quite stressful for some people, and that can actually keep them awake at night. So, but most hospitals now have electronic systems anyway, so you will be able to see from home what is happening actually. But generally, I've never had any problem because most of the resident doctors that I've been involved with who are on the ward, they've been quite good. And yeah, another con is no acute medical on call, so which means you get less exposure to medicine as such, but you do pretty much a lot of medicine for your own patients anyway. So you do not get a CCT in acute medicine, and some people would like that because if they have that, the demand for acute medicine is quite high at the moment, so the job prospects can be good. Not that for hematology they are not, because there are a lot of jobs, at least for now, for hematology consultants. And you could Google this. You will see lots of jobs at the moment, and you probably would very likely see some near to your hospital, your local hospital as well. And after this, I will briefly mention why I chose clinical hematology, because I actually wanted to become a cardiologist from the start. When I came here, I had my, foundation, and I core medical training rotations oriented around cardiology. So I picked those rotations that had cardiology in, and I had built a good CV in there as well. But the more I worked, I actually started getting bored, because it was just the same thing over and over again. So I actually had a meeting with my supervisor, and he's like, "Okay, so you want to do cardiology?" I said, "Yeah, that's the plan." He said, "Okay, so do you want to do intervention?" I said, "No, no, no, I don't want to do intervention. That's why I didn't become a surgeon." I said, "Okay, do you want to do devices?" I said, "No, again, it's not my thing to be doing procedures and things." Okay. Do you want to do heart failure medicine? I said, no, because you just be titrating the diuretics all the time. Of course, they do a lot more than that, but that's what my perception was. He said, okay, then do you want to do imaging? I said, no, otherwise I would have done radiology. So he said, okay, do you really want to do cardiology? So that was the, first, this was actually quite late in my training. And I was like, yeah, I don't want to do that anymore, even though I wanted to do that all along. And then there was some interest sparks that I had. I in I remember from my college, there was a hematologist who gave us a lecture which was actually not mandatory to attend, but they were so passionate about the blood cells and all of that, so that caught my attention. It never left my mind, and I always used to enjoy reading about blood and blood problems, because they sound quite interesting. And even when in co-medical training in handovers, whenever somebody would mention a hematology patient and things, I would have a interest, sparked in me spontaneously. So these two things basically took me to clinical hematology, even though up till co-medical training I had never worked in hematology other than a 1 or 2 weeks taster session that I did. So after my hematology, my core medical training, I applied for cardiology, radiology, hematology. Cardiology, respiratory, and hematology. And thank God I got in my preferred hospital in all of them. It was COVID time. My CV was very good, so I was quite high ranking. So I got in nationally, I think I was around seventh or eighth in the UK in hematology, and similarly cardiology and respiratory. So I actually got job in all the specialties that I wanted. Of course, there were no interviews. Maybe things would have been different, but yeah, thank God I got it wherever I wanted. And do I regret it? Not at all, actually. And I will just share briefly a story. So I have my colleague who was actually doing co-medical training with me, he becomes a cardiologist, and we both are involved with a patient who actually I knew, and they were quite unwell with pyrexia of unknown origin, and this was quite n- you know quite new into my training days. So maybe I had 8 months of training in my ST3. So the patients got pyrexia of unknown origin, their counts are dropping, nobody can find a cause, and just in those 6 months, by chance, I had been involved with some patients with something called HLH. That's a hyperinflammatory disorder where you have macrophages overactivation and causing tissue damage and things like that. So I thought this could be HLH, and I requested my colleague to do ferritin and triglycerides and things, and he was thinking like, the patient's so unwell, why does this guy want to start this patient on statins? Why is he checking his called lipid profile and stuff? So I had like a moment where I thought, if I had done cardiology, I would not have thought HLH, because he's in my position and he would be thinking this, and I would have probably been thinking this as well. So thank God I actually do not regret, and actually the patient got better. We suspected HLH, and this is what they had. And even though HLH, which we will discuss, I've got a presentation on there, is an illness with quite a bad prognosis, but thank God they were quite good. And as soon as we diagnosis. We started them on steroids and immunosuppression, and they were home within few days to a week, having been admitted for 2, 3 weeks with pyrexia of unknown origin. So that was quite a satisfying moment for me, and that was like, if I was having any thoughts like if hematology is right for me, that thought just left my mind and never looked back. So that's good. And I do like morphology and some the lies in hematology, as I've mentioned. So is that right for you? So I've discussed some pros and cons, so you can have a look. It's not right for everybody, but you just have to see where you are. But it's quite nice if you want to be part of a, quite a diverse specialty, and you want to treat patients and actually cure, say, you're interested in cancer care as well, so that you get cancer care, you get chronic conditions, you get acute conditions, you get conditions that quite serious and critical, but have got excellent prognosis if you treat them early, like TTP. You like lab work as well, and you don't mind exams, and exams are a piece of cake for you. I know some of you would be built for exams because I know people who would, you know, they would never fail an exam. So that's really good. So if that's what you are looking for, that's probably very good for you. And if you want any help with that, I could of course help. Just let me know in the comments below, and I could help you with whatever you need for your journey. So lastly, I just want to share briefly the plans for clinical hematology channel. I We plan to provide practical tips on hematology, but also work day-to-day working as a doctor, including focus on finances, which is important and it's quite neglected. And I will do a separate video for that. And I will also share resources about where to learn about hematology. And thankfully, there are so many nice hematology resources these days, most of which are free. I don't like paid resources very much, but most of them are free. Um, and They cover all aspects of hematology, so you will not regret it. I also plan to deliver some comprehensive lectures across a specialty, basically because even though there are lots of resources, most of them are focused mainly, say, on American hematology practice at the moment. Even though they are very good, they don't apply fully to the UK or practice or FRC path practice. But I will of course be covering topics that actually overlaps with the care everywhere. Then hopefully this will serve as maybe like a companion website or a channel for people preparing for FRC path exams, because I do plan to cover all all BSH guidelines. That's the plan. Might take me years to do so, but that's the plan. Of course, I will drop a few morphology bites here and there because hematology is not complete without morphology, and some short cases and diagnostic puzzles that people usually enjoy in their lunch breaks. But overall, our content would be guided by your feedback. So whatever you like, we will try to focus more on that, because this is for you, and to help you with your hematology journey. So that's all for today. If you want to stay connected, please do subscribe. And if there are any suggestions, let me know in the comments below. So most of the lectures will be uploaded on YouTube that I do in the future. But if you want to attend those sessions live, just scan this QR code, and we will get in touch with you whenever the next session is due. And you can then attend the session live and ask direct questions. So let me know if there's any other thing that you really want to know about hematology or medicine in general, and I will be happy to help you. Thank you for your time.